Mhm.
Copy my
Um,
computer so that I've got it and then I can upload it to Dropbox after.
okay, maybe
Okay.
don't record yet as for now, Larissa. Or maybe you want to bring people in already? Yes, let's
I've
bring.
started, I can always
They're coming
down and
in.
cut this stuff out.
Okay.
Yeah. We have six attendees so far.
Okay.
Somebody is a note
We're gonna
taker.
wait only a few minutes, but not so long, Pragashini. It's okay, people will join because time is very short. It's...
Yeah.
Les traducteurs, vous êtes prêts? C'est bon? Samir and Rola,
Yeah.
all good?
Yeah.
Ok, super. Ok.
Okay, so we have about 4 attendees so far.
Okay, bring them in.
Yeah.
Oui, they're here, Pragashini. Huh? They're just not in the screen, but they are here.
Yeah. They're under the attendees.
Yes, so they can hear us. Good morning.
Yeah.
Good morning, Bactrin, James, and Janet. We are just waiting a few minutes before starting, hoping some people will join us on the road. Welcome, everyone.
I think we should give it another 3 more minutes, Nadia. But there's like 5 people that have
Okay,
joined.
okay.
Give it another 5 minutes. Let's see.
Yes, another 3 minutes.
Shall we give it another moment?
Yes, yes. Welcome, everyone. We're waiting a few minutes, other people join.
Casey, I sent you a message on the chat.
I'm answering it right now.
Okay, thank you. All right, cool, cool. Thank you.
Welcome everyone. We're waiting still a few minutes, other people join.
Moi, je le reçois, donc je ne sais pas pour les autres.
Wanted to say hi to everybody. All the best in your deliberations.
Thank you, Bactrin. Hi, everyone. I think, Pragashni, we should start in a few minutes now. Huh?
So go ahead, Nadia.
Oh, I think you're starting
Yeah.
with a housekeeping, with a
Okay.
welcome.
Good afternoon, everyone. Good morning for those that are just starting their day. Thank you so much for joining this webinar. I know we're in a difficult situation at the moment, but you've made the time to make yourself available to join us for this very important topic, and we would like to thank you for this. Please be aware that the webinar is being recorded, and if there's any objections, please let us know regarding the recording. To kickstart this webinar on Mpox, all you need to know about Mpox, I'd first like to go over a few housekeeping rules. Not rules so much, but to let everyone know that if you require French interpretation, please click onto the globe, which is on your right-hand side, and you'll be able to hear the interpretation in French. So to kickstart or kick off this very important webinar, this webinar will consist of the official launch of the Mpox fact sheet, which was developed late to early, actually late last year. And the fact sheet provides comprehensive information on prevention, treatment, education, as well as the impact of Mpox on vulnerable populations such as people living with HIV, infants, as well as children. So for today's agenda, I'll go through the meeting logistics and introductions. Nadia Rafif from ITPC will go through the welcome. I didn't introduce myself. My name is Pragashni Murugan. I'm the program officer working under the Build Resilient Communities Strategic Focus Area at ITPC. I work very closely with Nadia Rafif, who's our advocacy and influence lead, and she will take us through the official welcome. Tracy Swan, the clinical advisor, will also take us through the insights into the Mpox prevention and treatment. She has been instrumental in writing this fact sheet. There will also be an open Q&A session for you to go through your questions and answers or share any comments with us. We look forward to hearing from you. Ange Mavula from the Democratic Republic of Congo, who forms part of the Community Advocacy Network, will also share his experiences on how on the role that communities have played in responding to Mpox, specifically within DRC. And we'll also we'll have a session, a Q&A session where you can ask how many questions you want, and thereafter we will go through the closing remarks. So our panelists for today are Nadia Rafif, Tracy Swan, and Anj Mavula. So the Mpox fact sheet was officially launched, and it's also translated in French, Spanish, as well as Arabic and Russian. Please feel free. I will post this link onto the chat. Please feel free to access the English version of the Mpox fact sheet. The other translated versions will follow very soon, probably just after this webinar. Thank you very much. Over to you, Nadia.
Thank you very much, Pragashni, and welcome everyone. Yes, thank you to be here. As Pragashni is here, we are in the middle of a crisis with the US freeze on many of its funding for foreign aids. And of course, the HIV response is impacted, but not only, right? We are talking broadly, and the response to Mpox is also certainly and will certainly be impacted. So it's a critical moment, right, to talk about epidemic and what it's mean, where we are now, what can we do as community to start with, and let's continue together to address also the ongoing crisis. So since 2022, Mpox has been reported over 130 countries. And since July 2024, it has been declared as a public health emergency by WHO, as well as by the Africa Center for Disease Control and Prevention. So at the end of this year, nearly 15,000 individuals across 20 African countries have tested positive for Mpox, and the cases are still rising. We hear more, other countries also. So it's not only in 20 countries as of today. So why did we decide to do this webinar and fact sheet? Because the risk of serious illness and death from Mpox is highest among vulnerable population, children, people who have weak immune system, including people living with untreated HIV, and during pregnancy. So we also wanted to do this webinar because there are a lot of questions among community around vaccine, right? Who need to be vaccinated, when, where do we have access to Mpox, etc., etc. Prices are still very high, and we're going to hear from Tracy about that. Activists are working on a way to improve access to Mpox vaccine, like we did for COVID-19, and that's something also you need to be aware. So without further ado, I want to give the floor to Tracy Swan, who did develop the Mpox brief together with ITPC, and will introduce, some of the main information you should know as of prevention, vaccine, and other critical issues. So without further ado, the floor is yours, Tracy. Thank you, everyone.
Thank you, Pragashni and Nadia. First, I really want to thank everyone for showing up for this. I know it's been a terrible 2 weeks with all the PEPFAR shutdowns and a lot going on, and people have a lot of other things on their mind, and I really respect that. Second of all, I'm going to go over everything that I'll cover. I'm also very happy to answer questions. And last but not least, to my great embarrassment, I'm expecting a delivery, so excuse me if my doorbell rings and I have to run out for a second and disappear. And without any further ado, can I share my screen? Yes. Oh dear, now you can see what kind of chaos my work life is in. Okay, where is it? Can all of you see these in great,
Line mode.
great.
Well,
Also, I want to thank the interpreters as always. I will try not to speak too fast, and I really appreciate your contribution. Thank you. So I'm going to be just telling you what Mpox is and going through a timeline and a description of the different sort of virus families of Mpox, which are called clades. We're going to take a look at where Mpox is being found, what part of the world is the most affected, and what country is the most effective. I'm going to give you the most recent epi data, talk about how Mpox is passed between people, what the symptoms are, and the complications, and who is most vulnerable, particularly Mpox and people living with HIV, testing for Mpox, care and treatment for Mpox, and then prevention. I'm going to talk about vaccines, who should be vaccinated, and also how to avoid getting and passing on Mpox, whether or not you can access vaccines, because we know that not everybody can, and what work is being done to improve access to Mpox vaccines. So Mpox is a virus from the same family as smallpox, and it can cause a very mild to life-threatening illness, which depends on a bunch of factors, like how healthy a person is, whether they're malnourished, what kind of access to health care they have, and other things. And smallpox vaccines can also prevent illness from Mpox or lessen the severity of illness. This is known as cross protection because these viruses are from the same larger family. Now, this is important because a lot of what we have to prevent Mpox, like the vaccine and some of the potential treatments, were developed to fight smallpox. Smallpox was eradicated in 1980. But a lot of countries, particularly high-income countries, have concerns about bioterrorism. But anyway, because smallpox was eradicated in 1980, which was a big triumph for global health, people stopped getting vaccinated. So this left people vulnerable to Mpox, but no one realized that at the time. Luckily, high-income countries did keep making and stockpiling smallpox vaccines in case of bioterrorism, although unluckily, as is obvious, they're not sharing them as they should. So just a timeline. The first case of Mpox was discovered in Denmark in monkeys that were being used for laboratory experiments. The first human case wasn't discovered until the 1970s, and it was reported in a 9-month-old baby boy in the DRC, and he was the only person in his family who had never gotten vaccinated against smallpox. And since then, Mpox has continued to circulate in Central and West Africa. And first, it began to spread in rural and forested areas, from infected animals to young people who didn't have the vaccines for smallpox. And then over years, it began spreading from infected animals to people, and then from people to people. So the way it started spreading from people to people was initially household contact, caring for sick people, handling their bedding, their clothes, their towels, etc. But in 2022, Mpox began to spread across the globe, and it was passed by close physical contact between people, which includes sex. So first, it started spreading sexually and then among household members. So gay men and other men who have sex with men were the most affected population at the time. And in July, the WHO declared Mpox as a public health emergency of international concern, which oddly is pronounced as fake. So in 2023, a different variant of Mpox called Clade 1b, and I'll talk about this more in a minute, began to spread in the DRC, first among sex workers and their partners, and then into households. And it turns out that clade 1b spread really easily. In 2024, it continued to spread in the DRC and then to adjoining countries, leading the WHO to declare a second public health emergency of international concern, or FAIC. And as of now, Mpox is still spreading against an inadequate global response. So I want to talk a little bit about the Mpox family. The global outbreak in 2022 was caused by clade 2b, sorry. And clade 2b is still spreading at low levels in many countries. And it's mainly passed from person to person by close physical contact, including sex among households during pregnancy and childbirth, and from bedding, clothes, and towels used by a person with Mpox, delivering healthcare to a person with Mpox, and even from respiratory droplets inhaled when you're very close to somebody, although that's not as common. Gay men and other men who have sex with men have been the most affected population, and many of them are also living with HIV. Mpox has added to the stigma and discrimination that these men already face. And clade 1 Mpox, especially clade 1A, can cause more serious illness and death than clade 2 Mpox. So there's clade 1A and clade 1B. 1A originally spread to people from contact with infected, sick, or dead small mammals like rope squirrels and some other specific types of rodents, shrews, and from bites and scratches that happen during hunting, butchering, and by eating undercooked meat. And this happened most commonly among people under age 15, but cases of 1A are now being reported in adults. And 1A now seems to be spreading by close physical contact between people, which is concerning because it does cause more severe illness and death than clade 2. Clade 1b is also concerning because it seems to spread more easily than other forms of Mpox. And it's been spreading from DRC to nearby countries, and travel-related cases have been reported in many other countries. And clade 1b is transmitted by close physical contact between people, from contaminated bedding, clothing, and towels, needle sticks and tattooing, and from inhaling tiny respiratory droplets. So where is Mpox found? You can see from this map, which is also included in the fact sheet. So I'm not going to spend too much time on it so that, we can answer some questions. But you can see that there are different areas where clade 1 and clade 2 are, and some countries where clade 1 and clade 2 have been found, and other places where it's not being reported. So what part of the world is most affected? The African region is most affected. And here's a map of African countries reporting laboratory confirmed clade 1 Mpox, either in the past or currently. And you can see the dark purple is during the 2024 outbreak. The lighter purple is it's been spreading, but not last year. And then the light purple is no clade 1 reported last year or no data. So DRC is the most affected country, followed by Burundi and Uganda. The violence in Eastern DRC really is complicating the response to Mpox. And new travel-related cases of clade 1b have been reported in China, Germany, Thailand, the UK, Northern Ireland, and the US. Azerbaijan has just reported its first Mpox case. We don't know the clade. But what that can tell you is, in a small way, it's really beginning to spread across the globe. And the last update was from the WHO multi-country external situation report, published on the 28th of January. So the total number of confirmed Mpox cases in all of Africa from the 1st of January 2024 until the 19th of January 2025 was 20,345. I just want to mention there's a big difference between confirmed and suspected cases because access to testing is really limited. Like in the DRC, less than 10,000 cases were confirmed, but there are almost 44,000 suspected cases. So there's a big difference. So what we know about what's confirmed in Africa, the DRC, 14,530 cases with 43 deaths. Burundi, 3,116 cases and 1 death. And Uganda, 2,031 cases and 10 deaths. So this is sort of a picture, but there's still a lot of information we might not have. And then WHO offers a risk assessment. The last one was in November 2024. Clade 1b predominantly affecting areas where it's not common in the Democratic Republic of Congo and neighboring countries, high risk. Clade 1a primarily affecting endemic areas for Mpox where it's common within the DRC, high risk, because both Clade 1a and Clade 1b are circulating in the DRC. Clade 2 Mpox observed in Nigeria and other countries in West and Central Africa, moderate risk. And Clade 2b associated with a global Mpox epidemic, moderate risk. So I'm just going to move to transmission again, just to underscore it. Can spread from animals to people, from person to person through close contact and sex and inhaling droplets. And people who are ill with Mpox need to isolate until their sores have scabbed over and healed, and there's a layer of new unbroken skin where their sores were. The symptoms of Mpox start within 1 to 21 days after someone becomes infected, but usually within a week. They can last for 2 to 4 weeks or even longer in immunocompromised people. And they include a rash, fever, swollen lymph nodes, sore throat, headache, muscle aches, low energy, and back pain. And what does an Mpox rash look like? So it will usually begin at the point of contact that someone had with an Mpox sore, whether that's the genitals, the anus, the rectum, the anus or the rectum, or on a person's face. Then it spreads to the body, the palms of the hands, and the soles of the feet. So some people only have a few sores, but people with severe Mpox may have hundreds to even more than 1,000 sores. And it starts as a flat sore, then turns to itchy, painful blisters, which can become infected and eventually scab over. And who's vulnerable to severe Mpox? Most people recover, but some people become very ill and some people can die. The complications include blindness, pneumonia, bacterial infections in different parts of the body, and permanent scarring. And the risk of severe illness and Mpox from death is greatest during pregnancy. For people living with HIV, if they're not on ARVs and they have a low CD4 cell count, which would be less than 200 cells, and if their CD4 cell count is low and their viral load is high. Now, the thing that's problematic about this is many people don't know their CD4 cell count. They might not know that they're living with HIV. They might not know that they have a high viral load. And I'll get into some recommendations a little later in the presentation. And infants and children are also particularly vulnerable, especially if they're malnourished. So what about Mpox and HIV? People who have a positive HIV test result should be offered HIV treatment. People with untreated HIV who are diagnosed with Mpox should start HIV treatment. And people who have Mpox and HIV with a low CD4 count need to be closely monitored. Okay, so ideally, HIV testing should be offered at every place where Mpox testing is offered and where Mpox vaccines are offered. So Mpox is tricky to diagnose because the symptoms are similar to a lot of other illnesses: measles, chickenpox, bacterial skin infections, herpes, scabies, syphilis, among others. So testing is really important to confirm or rule out the cause of a person's illness. For example, measles vaccination rates in parts of the DRC are low. And there have been outbreaks of both measles and Mpox in some parts of the DRC. And some poor children have been actually diagnosed with measles and Mpox at the same time. And what you might want to do to care for someone would depend on which infection they have, if they have both, etc. And the way you test someone is you swab their Mpox sores, and then the samples have to go to a lab. And access to testing has been really limited in some places, including the DRC, and results can often be delayed. People sometimes leave their care center before they ever get their test results. And the tests have been really expensive, like $20, despite pressure from activists. But Morocco has just produced a WHO approved $5 Mpox test, which is very good news. There is no approved antiviral treatment for Mpox, but there's a lot of research underway. I think one of the most important things is about stigma. It can prevent people with Mpox from seeking care, but it's really important. And research has really proven that supportive Mpox care saves lives. Now, what I mean by supportive care is nutritional support, especially for malnourished children, hydration, pain and fever medication, caring for sores to prevent infection and lessen itching, and treating secondary bacterial infection. And I've spoken with a couple of clinicians, and they say if someone has severe Mpox, they need the same level of skincare as, say, someone who got severe burns. So it's very resource intensive for healthcare workers. But there was an Mpox treatment trial, and everyone in the trial, it happened in DRC, everyone in the trial who had been diagnosed with Mpox was admitted to the hospital for 2 weeks. And they got all of this supportive care plus an antiviral. And at the end of the trial, they realized the antiviral didn't change how long it took people to recover, but that the death rate among people who got both supportive care was less than half of the death rate among people who didn't get supportive care. So it really does save lives, and there's no room for reinforcing stigma and discouraging people from seeking care. And if a person falls ill with Mpox, there's some things they can do to take care of themselves. First of all, if you feel really ill, seek health care, but also take medicine for fever and pain. Ask people for help and support. Drink lots of fluids, rest as much as you can, try to eat well, keep your skin clean and dry, take warm baths with baking soda or Epsom salts. Try not to scratch your Mpox sores. Use a saltwater rinse for mouth sores. And all of this, although it's not always possible, isolation is recommended so Mpox doesn't spread to other people around you. And I will talk about that a little more later. I want to quickly go over the vaccines. So because smallpox and Mpox, again, are from the same family of viruses, smallpox vaccines can prevent or lessen illness from Mpox. In other words, they're cross-protective. And there are 2 WHO recommended Mpox vaccines, MVABN and LC16. MVA is given as 2 doses a month apart, either by injection into the arm or under the top layer of skin under the arm, sort of like a TB test. If you get 1 dose of MVA-BN, it should reduce the Mpox risk of illness by about 75%. If people get both doses, it goes up by about 85%. So if there is a shortage and you want to stop the outbreak in its tracks, some countries are saying it's better to give more people 1 dose and less people 2 doses because the effectiveness is close. And this vaccine, MVA-BN, is made from a weak form of the vaccinia virus that can't cause illness in people. So it can't reproduce in a human body. And so that means this vaccine is safe in people with weakened immune systems, in children's ages 12 and over, and during pregnancy. And the most common side effects are pain, redness, and swelling at the injection site, and headache, muscle ache, and feeling tired, although none of them has been described as severe. So the other vaccine, LC16, is a single-dose vaccine made in Japan. It has a weak form of a vaccinia virus in it, so it has the potential to cause illness. It can't be given during pregnancy to people with certain skin diseases and to people with weakened immune systems. This includes people living with HIV who have a CD4 cell count of less than 200 cells. And it's given by multiple jabs from a 2-pronged needle. A sore called a POC will appear where you got the vaccine 6 to 12 days later. It has to stay covered until it totally heals because a POC is infected with vaccinia virus. Don't touch it, because if a person touches their POC and doesn't wash their hands and then they say itch their eye, it can spread to other parts of their body or even to other people. And the POC heals in about 3 weeks. Now, the reason why LC16 is super important is it's approved for ages 1 year and above. And young children are being very badly affected by Mpox. So it's super important to have a vaccine that protects them, even though, in a perfect world, MVA-BN, which is safer, could be used. And there is a trial that's starting in children younger than 12 to see if MVA-BN can be used in younger children. So the common side effects from LC16 include the same swelling and redness at the injection site, also fever, chills, rash, and swollen lymph node. And this doesn't mean the vaccine made somebody sick. It actually means your immune response is responding to the vaccine. So people aren't usually happy when they feel crummy after getting a vaccine, but it is a good sign that the vaccine is activating your immune system. So who should get the Mpox vaccine? Ideally, everyone during an outbreak, but access is currently limited. So this means vaccines need to go first to people who are at the highest risk of Mpox, healthcare workers and people who have had close contact with someone who has Mpox. And it takes a few weeks for immunity to build up after getting the vaccine. And it will lower the risk of Mpox and prevent serious illness. But people can get Mpox more than once, even if they've been vaccinated. So prevention is still important. And what does that look like? So people who don't have access to vaccines can lower their Mpox risk by making sure to share information with your community about Mpox and avoiding close contact, including sex, with people who have a blistery skin rash. Taking a break from sex, having fewer partners during an outbreak. Condoms do offer some protection, but they don't cover all the places where people have sores. And share information with sex partners. Avoid the close contact or sex if you yourself have Mpox. Wearing gloves and a mask if you can while caring for someone else with Mpox. Washing or sanitizing your hands often, especially after contact with a person who has Mpox in their clothing, towels, and bedding. Staying away from sick or dead animals that carry Mpox. And if you happen to touch them, wash your hands afterwards and only eat well-cooked meat. Getting tested for HIV and starting HIV treatment will keep your immune system strong and lower your risk of serious illness or death from Mpox. And if you have Mpox, seek healthcare. You can lower the risk of passing it to other people by staying by yourself until your sores are completely healed. If this isn't possible, you can take other steps. Keep the windows open, keep your sores covered when you're near other people, use a condom for 3 months after you recover, wash your hands a lot, and avoid close contact. You can wear a mask, suggest that other people in your household wear masks and gloves if they're touching stuff that you've had contact with, if you have Mpox. So let's talk about the need for Mpox vaccines versus access. In August 2024, the Africa CDC called for 10 million Mpox vaccines by the end of the year. But as of January 28th this year, less than 500,000 Mpox vaccines have been delivered to 6 countries in Africa, and 4 of them have started vaccination. About almost 500 million doses of Mpox vaccines are expected in 2025 from multiple countries and organizations. So it's 1.73 million doses of MVABN from different sources, 50,000 doses of ACAM 2000 from Emergent Biosolutions. I didn't talk about that vaccine. It's not WHO recommended yet, and it has a lot more safety issues than the other 2, and I'm not sure how it's going to be used. The instructions for how you're supposed to care about for your vaccine site are like, I don't know who's going to do this, like wear gloves, cover yourself, change the bandage, wash your hands, do this and that for weeks and weeks. That's a more complicated vaccine. Japan donated 3.05 million doses of LC16, which was very generous. But, there's far more need than access. So part of the access barriers are the patents. Pharmaceutical companies have patents giving them the right to produce and sell MVABN and LC16 at the price they choose for at least 20 years. For example, it probably costs $4 or less to make a dose of MVABN, but the company that owns it, Bavarian Nordic, is selling it to UNICEF for $65 a dose. Okay, that's completely unjustifiable. I think given the larger context of, the shuttering of PEPFAR programs, it might not be possible to launch a global campaign, but there has been outcry and there should be more about this ridiculous pricing. Donations, unfortunately, although they can help, they're not sustainable because you can't always rely on a steady supply. And sometimes, as happened with COVID, countries get the vaccines a month before their expiry and don't even have time to properly distribute them and roll them out. So ideally, countries need to be able to produce their own supplies of Mpox vaccines or buy them from a nearby country at an affordable price. But patents and other intellectual property barriers are currently preventing this. And voluntary measures, like voluntary licenses, have limitations. Voluntary licenses are controlled by pharmaceutical companies. They decide which countries are eligible to purchase affordable versions of their products, and sometimes even on who can use their products or how they can be used within a country. For example, Bavarian Nordic has been talking since August about how they really want to expand access to their vaccine in Africa. So they granted a voluntary license to Serum Institute of India. It allows Serum Institute to produce vaccines for India's national market only. And as of last year, there were 3 cases of Mpox reported in India. So it's kind of ridiculous saying here you can make it for everyone when it's not really a priority. But it also allows the company to produce vaccines for Bavarian Nordic, which could then resell them at a higher price to other countries. So that's not really a good voluntary measure. On the other hand, governments can issue a compulsory license, which allows that country to produce affordable generic products or generic vaccines without getting permission from the patent holder. And civil society and activists can file patent oppositions either before or after a patent is granted. And civil society and activists can also work to strengthen the patentability criteria at the national level, which makes it harder for pharmaceutical corporations to get patents on their products. And ITPC's MakeMedicinesAffordable.org is working on access to medicines and vaccines, including Mpox vaccines. And there is the website address, and you also all will receive these slides. So I thank you so much for your time and attention. I'm going to stop sharing, and if we have time, I'll answer questions now. If not, I'm happy to do it after the next presentation, which I'm very much looking forward to. Thank you, everybody.
Okay, thank you, Tracy. I do have a question from Grace Nayarit. She's one of the Community Advocacy Network Advisory Group. She works very closely with key populations, which are the sex workers. So she says, as forming part or working with the sex worker key populations, we are working on advocacy on Mpox regionally, and sex workers in the DRC are currently at increased risk of Mpox, largely due to their reliance on visible symptoms from clients. Given the ongoing conflict and the migration of people fleeing the war, which further exposes them to infections, what measures can be taken to raise awareness and help sex workers identify invisible signs of Mpox to reduce their vulnerability?
Okay, well, first, thank you for your really important work, Grace, and that of your colleagues. I think the most important thing is gathering groups of sex workers and explaining transmission. But if people don't have visible sores, you can't tell whether they have Mpox or not. So you can't really decide whether you're at risk from having sex with someone. There has been advice for many decades about sex workers examining their clients for sores, but that's not always possible. And it can put sex workers at risk. Condoms will reduce the risk slightly. But again, if someone has a sore on their stomach, the condom doesn't cover your stomach or other parts of their body where you will have direct contact. I think one thing that's really important is if there are any vaccination programs, I don't advocate dishonesty, but sex workers are a very vulnerable group. And there's nothing wrong with saying, I fear I've been exposed to Mpox. I need the vaccine, and getting it if it's possible. I'm sorry I don't have better advice than that, but that's really all I can tell you from my knowledge. Thank you for the question.
Thank you, Grace. So I have a question, Tracy. In South Africa, we did have isolated cases of Mpox, especially in I think it was isolated to Johannesburg and mainly Durban. So this caused a little bit of a fear or a sense of anxiousness that we probably will have to deal with another outbreak like COVID-19. So there was limited knowledge and so forth. Do you think it will be advisable to strengthen immunization programs since infants are also prone or at risk? Everybody's at risk. And because is it a misconception to think that if you have your measles or your chicken pox jab, you as a child, you are not, or you are less likely to get it, or you'll be
Smallpox.
immune?
The smallpox vaccine is the only one that reduces the risk of Mpox, not measles or chickenpox or other vaccines. So an Mpox vaccine is recommended. I'll tell you what I think is a really good idea if health systems can do it. So Bavarian Nordic keeps saying that they can't mass produce the vaccine because they're not sure if there's a market for it. So some
Okay.
public health experts have said every country should have a stockpile of these vaccines in case there's an Mpox outbreak in the country. I actually totally disagree with that. There are places where those vaccines are needed right now. All those vaccines should be going directly to where they're needed. And if you want to stop these outbreaks, particularly in countries where Mpox has been circulating at low levels for decades and flares up, they should be routine for everyone as part of a vaccination strategy and a public health program. This will protect people. It will lower the risk of outbreaks, and it creates a much better market for people who are selling their vaccines. So it's more of an incentive for local production, et cetera. And as far as lowering your risk, really the way you get it is from close physical contact. If someone in your household, say, has sex with a person who has Mpox, and then it's in your household, there are measures you can take that I outlined, like the person can isolate, people can wear masks and gloves, keep the windows open, etc. But your average person isn't really at super high risk from just going about their business in the world. It's close physical contact. It's not like COVID where it was like, ooh, someone breathed next to me on the bus. I've probably got it. So hopefully that gives people some ideas about, measures where they can lower their risk. For example, if you're going to a super crowded outdoor music festival in the summer, you may want to stay in areas where people aren't who are wearing, summer clothes aren't pressed right up next to each other. You may want to stand a little back, things like that. But otherwise, it's really close physical contact or, trapping tree rats and shrews and things like that and butchering them and eating them when they're undercooked.
Okay. Okay, thank you. Bakchan, you can unmute yourself and your hands
Yeah,
are raised.
yeah, yeah. Thank you. Very well done, Tracy. Very good job. Very rich content in there. I just wanted to make a comment in response to Pragashni's question about whether or not vaccines used for measles or other viral illnesses can help deal with Mpox. Essentially, if you remember what Tracy said earlier on, that viruses belong to different families. Yeah, they behave differently. And the immune system, once the human immune system is exposed to whatever virus, the response is usually different. Yeah, the antibodies that are made in such a way that they are very specific to specific viruses, and that's why different viruses that come from different families, vaccines might not work, and that's why also the smallpox vaccine was able to be useful in generating the Mpox vaccine. So it's all about specificity to what you are manufacturing as a vaccine, intending to what particular virus. I just wanted to add that just so that people don't think any viral vaccine can be used to deal with any viral infection.
Thanks for that,
Okay,
Bakchan.
Okay, so just one more comment. I think we have about 2 or 3 minutes, Tracy, before we hand over to Anj, Waki Cole from Liberia is saying that there are two types of vaccine, but I would like to know more about the LM16.
Okay, so the LC16, the Japanese virus, is given in an old school way. It has a really scary name. It's called scarification. But what that really means is a needle with two prongs on it is dipped into a vial of vaccine, and then the skin is very lightly jabbed with it like 15 times. That's how the vaccine is introduced to your body. And as your immune system responds to it, it forms a little sore called a pock. That means your immune system has recognized it and is making a response. And that pock has a little bit of not smallpox virus, but something called vaccinia virus that can be infectious if it escapes from the pock. So what I mean is it's not going to jump out and run out of the pock by itself. But say I got the vaccine and it's itching, and I scratch it and I don't think about it, and then I go like this, I can spread that virus into my eyes, which can cause me to go blind. So the thing about this virus, which is safe and very effective, is that people need to care for their pock, or the little spot where you get the virus, very carefully for a few weeks, keep it covered, wash their hands, etc. So they don't pass vaccinia to other parts of their body, and they don't pass it to other people. Like, say my friend comes over and I've been scratching at my pock and my friend's pregnant. I'm like, hi, how are you? And I shake her hand and I haven't washed my hands and she itches her eye. That's the kind of way it can spread. So people are going to need, healthcare workers are going to need to understand how to administer it because it's a different needle. And along with the vaccines that got donated, the needles have also been donated. And I know at least in the DRC, there have been announcements that healthcare workers are going to get trained to administer it. People need to know how to care for their POC or vaccine sore. And so it's going to take, it's a little different, but again, it's the only one that's recommended for everyone who's over 1 year old. The MVABN is safer, but that's not to say that the LC16 is not safe. It is safe, but it contains a weak form of vaccinia that can copy itself a little bit. The vaccinia in MVABN cannot copy itself, so it can't make you sick or anyone else sick. It's a slightly less complicated, slightly safer vaccine. I think it's very helpful to have the LC16, particularly for children. It's a little concerning that, you know, they're malnourished kids or kids with advanced HIV who probably shouldn't get the vaccine. And I don't know what the screening process is going to look like in the midst of an outbreak and a public health emergency. But I think the benefits really outweigh the risk. MVABN is a more modern vaccine. It was invented to fill the need for a safer smallpox vaccine. And that one is 2 doses. It's more effective after 2 doses than 1, but it's 75% effective at preventing infection after 1 dose. I hope that's clear enough. If not, I'm happy to answer more questions. And there's more information on the fact sheet as well. Thanks for the question.
Okay, thank you, Tracy. That was really informative. And as Tracy mentioned, you can access more information on the Mpox fact sheet. I have posted the link to onto the chat, but it will also be shared more broadly or more widely after the webinar. So now I would like to hand over to Anj Mavula, who's going to take us through the experiences from the perspective of being in DRC, of first-hand information For those that are not French speaking, please go to the English interpretation where interpretation will happen from French to English so that we can follow what you are saying. Okay, so I'm going to share your screen, your slides, Ange, and thereafter you are good to go.
Tu es avec nous, Ange, ça va? Juste pour être sûr. Ange, est-ce que tu es avec nous? Pogachnik,
Bonjour tout le monde.
super,
Ouais,
très
je suis
bien.
prêt.
Tu es là, d'accord, très bien.
Bonjour tout le monde.
Good morning, everyone.
Je vais vous présenter
So,
rôle
I will be presenting the
des
role
communautés et de la société civile
of
dans
the
les ripostes
civil
en cas
society
de
and
Mpox
communities
en
in
République
responding
démocratique
to
du Congo.
Mpox cases on DRC.
Voilà, ça c'est la
So,
situation
here you
épidémiologique. En fait,
have
vous
the
voyez les
epidemiological situation. You
bleu,
see the different
plus
colors,
foncé,
blue, the dark
détermine en fait
blue,
le nombre de cas suspects
determining
par
suspected
province.
cases
Vous
by
avez les
province,
taches
and you
bleues
have
marquées
the
qui
red dots
indiquent le nombre de décès
indicating number of
dans
deaths
les différentes provinces selon que
in the
c'est
different
de 1 à 5
provinces
jusqu'à
from 1
378
to
décès.
5 until
Ça,
to
c'est la situation
378
cumulée
deaths. Now, this is
de
the
la première
cumulated
semaine
situation from the first week
44e semaine de 2024.
till the fourth week of 2024.
Ça, c'est le tranche d'âge qui sont
So
le
here you
plus
have the
contaminés.
different
Vous
age
voyez, les
group,
femmes qui ont de 10
the
à 14
most
ans jusqu'à
contaminated
34 ans,
or
qui sont
infected
les
age
cas
group
les plus contaminés. Vous
from
voyez
10
ici
to
la
34 years
situation
old. And you see the
à la
situation.
deuxième semaine de 2025. Nous
The
avons
second week of 2025, we have a
63 cas
accumulation of
suspects,
13,671
confirmés
confirmed,
1328 décès.
63,600
Ça, c'est le
cases confirmed. So here is the situation on the national level. We have implemented a cell, which is an emergency operation for health, public health with the Ministry of Health, which roles were to elaborate the mapping of risks and resources, establishing management of emergency plans, coordination of the different interventions, and the watchdog, the health and sanitary watchdog about the situation.
Ça, c'est en fait,
Here you have the sum up of the involvement of civil society and communities in the response. So you have four pillars. The first pillar is about communication. As you see, communities are used for communication. Here it is about raising awareness and education in order to disseminate very accurate information in order to combat disinformation and also to mobilize communities. The second pillar is about testing. Here, the communities also are used and work on testing. The third pillar is about care and treatment. We know that within the community, if we do suspect a case, we need to report in the center for health and care. And the fourth and last pillar is about community follow-up, retention, support, and the CLM, because it is also about supporting patients by providing needed materials, for instance, or for psychological assistance, for instance, to help them. And the CLM is mobilizing civil society to be able to have the advocacy
actions for directive and guidelines on the political level, etc. And on the right side, you have the coordination of the social center working in collaboration with the different community in the framework of a social contract with a different structure of HIV coordination structures, because HIV also are or has accumulated experience since they started a long time ago. So we have a great experience in responding, and CLM, which is mobilizing the civil society, is also important to integrate other topics, such as the case for Mpox, and now
avec le COVID et maintenant avec le Mpox.
it was the case with the COVID and now with the Mpox. Next.
Ça, c'est les 3 niveaux de prestation.
Here you have the 3 different levels of intervention for the civil society, providing services, raising awareness, creation of the demand, follow-up by the communities with this observatory to give an advocacy in order to influence policies. And the third point is the community watchdog, and this is to alert critical events indicating any outbreak or a suspected case. So this is about raising awareness, how to alert the watchdog, solidarity and support, mobilization and advocacy in order to mobilize sources or to change public policies, and adaptation of the different interventions. This means that civil society is within the community, knowing the needs, could be able to readjust the response accordingly with the needs of the community, strengthen the resilience within a specific community that suffers every time these diseases, these outbreaks, these pandemics. And so this is to bring the community to resilience in order to overcome any negative effects of these disaster and outbreak. So here you have the case of vaccination campaign. You know that DRC has received different vaccines. So it's an organization of the community here working with the key population within this campaign of vaccination. Here again, we have this vaccination campaign at Goma. We are at Goma in the north of the country, right before the troubled days. I will stop here. Maybe I didn't use my 10 minutes, but I shall remain available to answer any of your questions.
Merci, Ange. Thank you very much, Ange. It's very important and critical to see how civil society play a role, and as always play a role, right? We saw that during COVID-19, also in crisis and emerging pandemic like Mpox. I'm very impressed, Ange, on what you have been doing in DRC, knowing also the context in DRC and the political crisis and event also, as you say, in some of the region. So that's very insightful, right? To see that not only you're doing community-led monitoring, trying to monitor stock, but also like delivering vaccination, bringing the key population to the health center. So very impressive knowing that you have a lot to do on the side also. Do you have any question for Ange and the situation in DRC, or any experience you want to share also on any response in your own country regarding Mpox? Do you have other experience similar to what Ange just presented in your own country? No, okay. Do we have question in the chat, Pragashni, for Ange or?
There's no questions at the moment. But can I ask? I can see some of the CAN members here. Nkechi, if you can hear me, can you unmute and let us know whether you have any questions or comments for Ange? Jean? Not sure. Ask them to unmute.
Sophie, I do not have any question.
Okay. Okay, thank you.
It's okay if we don't have any question for now. We can, we can stop the webinar a little bit earlier. Tracy presentation will be shared, including the recording and also the brief, translated in English, in French, Spanish, Arabic, and Russian, like Pragashni mentioned. So we will share all of that because I know many people wanted to attend the webinar today, but were not able, knowing the current crisis and emergency call that or meeting that everyone is having at country level. So we totally understand. And, when we were, okay, Ange, please, go ahead. Vas-y, Ange.
Ouais, je peux aussi ajouter
Yes,
pour
I would like to add, maybe for your information, since we have a little bit of time remaining, we do work,
construire un projet avec
or we do have a project with the Urum Institute. This is in South African University with the NINDL for neglected diseases in DRC. With regard to awareness raising for Mpox in the different centers where HIV patients are followed. So we have benefited from that within the institute and within the community around the center. We started finalizing terms of reference, and beginning of next week, we will start elaborating with the CUSP, which is the lead at the political level, to elaborate messages for communication. And this is to have messages that we can use in our activities and awareness sessions. This will start beginning of next week, and we will have this for 1 year. So this is an information I wanted to share with you, if useful. Yes, very important, Ange.
To ask you a question. Is the Global Fund supporting the effort on addressing the Mpox, for example, in DRC? Because I hear that you are looking out for other funder and other research institute, and that's great, and that's a good also insight for all of you that there is we need to showcase again and again that community are the best position to address quickly the response. So, but Ange, do you get funding from Global Fund also or not?
Oui, le Fonds mondial, vous avez vu les images que j'ai montrées
Yes,
là?
Global Fund, I showed this on the pictures. It is the Global Fund support through the UNDP, and they still do have money for Mpox at the level of DRC.
That's what I wanted to say. The Global Fund is one of the most flexible funds, and he put aside some funding to address emerging pandemic. They call it pandemic prevention and response. So there is, don't hesitate, if there is a need in your country to also discuss with the CCM about these funds. And Ange, I hope that the PowerPoint of Tracy and also the fact sheet in French will help for you to adapt and create your own sensibilization material. I hope it will be helpful. Any other comment before we close? Bon, très bien. Ouf. You will find the latest update information on there. Any final comment or remark? From the audience? Okay. Just before I close, I wanted also to mention that, at ITPC, we also have a strategic pillar, which is make medicine affordable. And they are also working, right, on access to COVID, to Mpox vaccine. And I don't know, Morgan, if you want to say one word on the work you're doing in the Make Medicine Affordable pillar regarding access to vaccine. Or Tracy, but if it's okay, it's okay. I can mention quickly that in this strategic area, we are also, strategizing about vaccine, and this is one of the topic area. So thank you, everyone, for being with us today. Knowing the existing crisis in the US, which is not only on vaccine, on HIV, but also broader on health, we really have to continue to push, more than ever, to push for community to be at the center. The CDC, the Center for Disease Control in the US, is also facing a lot of difficulty, and the CDC and other critical center were exactly monitoring, emerging pandemic. So there is a lot to do, and we are continue to advocate not only with US advocate, but also with country level advocate. And we will certainly go back to you to hear about the impact of the current crisis in your own setting and country to be able to strategize together. But as of today, thank you very much for attending the call, and we will follow up with sharing all the documentation. Any final word, Pragashni?
I think you said it all, Nadia. Thank you very much. I think we can say that it was a useful session today. We've added another disease area to better or improve our understanding. Thank you to Tracy and Ange for taking time, developing the fact sheet and developing their presentation, sharing their knowledge from the ground. And thank you to the interpreters as well. And lastly, thank you, Nadia, for your opening and closing remarks. And with that, we shall see you. CAN members, please don't forget tomorrow, 2 important meetings are taking place. So we look forward to meeting you tomorrow. Take care and have a good evening or good morning. Bye.
Thank you, everyone.
Bye.
Au revoir. À demain.
À demain. Thank you, Rola and her
Bye
team.
bye.
Bye-bye, Ange. Bye-bye,
Au
Tracy and
revoir,
everyone.
merci, merci, Lola. Au revoir.
Au revoir, tout le monde. Bye-bye.